来週は下がれそうだったけど。そこスイッチがありますよ。スイッチ入れてください。
これ、
はい。
はい、すいません。
入ってる。
本日は認知症サミット日本後継イベント本会議にご来場いただきまして誠にありがとうございます。まもなくサミットを開始いたします。開始に先駆けまして皆様にお願いをさせていただきます。一部予約席がありますが、予約席を除きできるだけ前の席からお詰めの上お座りくださいますようお願いいたします。
Thank you very much for waiting. We're soon starting the session. There are still seats available at the front rows, so please move forward. And please make sure that your the cell phones is switched off or at the silent mode. Thank you.
にてコーヒーの準備をさせていただいています。他のお飲み物については自動販売機が設置されておりますので、そちらをご利用ください。お席に同時通訳レシーバーがありますのでご活用ください。離席する際には同時通訳レシーバーはお席に置いて離席いただきますようお願いします。プレスの方はプレス受付にて同時通訳レシーバーをお渡ししますので、会場を退出する際にはプレス受付にご返却をお願いいたします。会場内は Wi-Fi によるインターネット接続が可能になっております。プレスの皆様、参加者の皆様や動線の妨げにならないようご注意ください。特に開会式の間は会議運営のため立ち入り禁止エリアを設けておりますので、何卒ご協力を願います。なお、開会式の様子はロボット展示の会場であるスカイスタジオにおいてオリジナル映像にてカンファレンスルーム1+2において日本語映像にて同時中継されておりますことをお知らせします。
皆様、まもなく開会式を始めますので、
Thank you very much for waiting. We are soon starting the opening ceremony, so please be seated.
お待たせをいたしました。
Thank you very much for waiting. Thank you very much for coming to attend this Global Dementia Legacy event in Japan from all over Japan and also from all over the world. We are starting the opening ceremony for the Global Dementia Legacy event Japan. On behalf of the organizer, we would like to welcome the Minister of Health, Labor and Welfare Japan, Yasuhisa Shiozaki, to give us an opening remark.
皆さんおはよう。
Good morning, ladies and gentlemen. I am Yasuhisa Shiozaki, Minister of Health, Labor and Welfare of Japan. Sir Mark Jeremy Walpole, Her Majesty Government Head of the Government Office for Science, UK, Dr. Shekhar Saxena, Director, Department of Mental Health and Substance Abuse, World Health Organization, as well as representatives of each country and OECD, and government officers and experts who are involved in care and prevention of dementia. Thank you very much for coming to this event. We are very happy to receive a video message from Dr. Dennis Gillings, World Dementia Envoy. I would like to also take this opportunity to thank Chairman of Health and Global Policy Institute, Dr. Kiyoshi Kurokawa. He is the sole member of World Dementia Council from Japan, and he's made a great contribution to the organization of this event. And in this event, we are very happy to see the presence of people living with dementia and their families, and I'd like to extend my heartfelt gratitude to you all for your presence. I would like to declare the opening of the main meeting of Global Dementia Legacy event Japan. This is a legacy event as a follow-up of the Dementia Summit held in London last December under strong leadership of Prime Minister Cameron in the UK. And this is one of the series of such legacy events. In June, hosted by the UK government, there was such an event on social impact investment. And in September, co-hosted by Canadian and French governments, this event was held on maximizing academia industry synergies. I would like to extend my great respect to these countries which have hosted these legacy events. This time, the theme is new care and prevention models. Japan is one of the rare countries which has long-term care insurance system to cover the entire nation. As such, it's very important for us to establish community-based general and comprehensive care system which provides medicine, care, accommodation, as well as life support, so that we can create a community where people living with dementia can live safely and securely. And from that perspective, we have certainly something to present to you, and we would like to also learn from the initiatives of the rest of the world. Yesterday, in the breakout sessions, the themes were discussed, such as providing timely and appropriate support, scientific aspect of dementia, living well with dementia in the community, enhance awareness and education in the society. And very active discussion took place on these 4 themes. And in today's meeting, we will have some discussion in depth on how to utilize ICT in this perspective. I'm sure that this meeting is going to be a very fruitful one for our future. Since 1985, I am the Japan side chairperson of UK-Japan 21st Committee. And Prime Minister Cameron's initiative in the UK, a variety of policies are promoted for dementia. And here in Japan, speed of aging is much faster. And in this country of Japan, I think it's very important that Prime Minister Abe takes a strong leadership to promote policies for dementia. At this juncture, I'd like to introduce Prime Minister of Japan, Mr. Shinzo Abe.
皆様
Good morning, distinguished guests, ladies and gentlemen, good morning. I am Shinzo Abe, Prime Minister of Japan. First of all, I would like to extend a warm welcome to everybody joining today, including specialists and government officials focusing on dementia care and prevention from all over the world, as well as individuals with dementia and their families. I am honored to host this legacy event in Japan, following on the G8 Dementia Summit. Welcome all to Japan. In Japan, an estimated 1/4 of elderly people are thought to either have dementia or to be in its preliminary stages. Rather than only consider how to provide care, we should also look to provide support so these people can live better lives with dementia, addressing the issues from their perspective. This is the type of society our cabinet is aiming to realize, where one can tackle any challenge. We'll do our best to enhance support at the earlier stages of dementia, working with teams of healthcare professionals and long-term care specialties. Creating a society in which people with dementia can live their lives with dignity is a worldwide challenge. As the most rapidly aging society, Japan should demonstrate a suitable social model for dealing with this issue. Now I'm asking the Minister of Health, Labor and Welfare to formulate a new action plan for dementia. Since 2012, we have been establishing infrastructure for medical care and long-term care services in line with the 5-year plan for promotion of dementia measures. The new plan will involve collaboration across government to implement this strategy in a holistic way to support the lives of people with dementia. In order to effectively tackle dementia, all countries should gather their accumulated wisdom and experience and share this knowledge. In Japan, for example, a cohort study on dementia will be conducted nationwide to expand research in pathology, cures, and prevention. We will strive to attain even higher quality results from such research in collaboration with other countries. In addition, Japan has been promoting a dementia supporters training program so that those with proper knowledge and understanding of dementia can provide appropriate support to persons with dementia and their families. The UK and Canada have also started similar programs based on our initiative. Japan plans to continue supporting efforts to introduce this program internationally. In closing, I anticipate this legacy event will produce a valuable exchange of ideas and best practices and support firm and steady progress toward international collaboration on tackling dementia. Thank you for your attention.
ありがとうございました。
Thank you. Due to his official duty, the Prime Minister will have to be excused. Now, this is the Dementia Summit, the legacy event Japan. This is Machinaga, who will be serving as MC. I have been working for NHK in dealing with dementia themes. It's very nice to meet you. From this point on, we'd like to have the welcoming remarks by honorable guests. First of all, the member of World Dementia Council, Dr. Kiyoshi Kurokawa. Just as was mentioned by the minister, today we have the World Dementia Envoy, Dr. Dennis Gillings, will be offering a video message. But before that, Dr. Kurokawa, please. Welcome to this event, Global Action Against Dementia, as I mentioned yesterday. And this is the Dementia Council, which was established in December last year at G8 Dementia Summit under the strong leadership of Prime Minister David Cameron and the Health Minister. There are 18 members here, and we have had the 3 previous meetings in Paris, London, and also the legacy event is to be held in Tokyo, and before that, that was held in Ottawa and London. Now, we have the Dr. Dennis Gillings. He is not available here, so he will kindly give us the video message.
Konnichiwa. Good morning. I'm sorry I can't be with you in person for such a fascinating event. The agenda is packed with exciting innovation in prevention and care, so I'm very sorry not to be there. I am, however, keeping up to date online, and thanks to the wonders of technology, will be able to catch up on everything I missed. The theme of innovation in care and prevention is one that I feel hugely passionate about. Having cared for my own mother, who lived with Alzheimer's disease for 18 years, the potential of good care to improve the life of someone with the condition is enormous. So that is why the incredible innovation in Japan and elsewhere to bring care to the home using technology and cutting-edge techniques is so exciting. I'm particularly encouraged by the potential of iPad and computer technology to allow remote care and connectedness. I found with my mother that having someone there able to provide support and reassurance was essential to her well-being. Allowing loved ones and carers to connect at the click of a switch opens up huge opportunities. While I am full of encouragement for all of these ideas, we must never forget that the very best care should be available to all, no matter what their circumstances or background. There is currently too much variation, both within countries and between them. We, on the World Dementia Council, are looking at how that can be evened out, as well as making sure that the very best ideas and techniques are shared globally so that best practice is available around the world. As I found earlier today, meeting people at the dementia ward at the Royal Hospital Chelsea in London, it is by concentrating on the smallest details that can make all the difference to how someone feels. There are personalized front doors for each patient, with a remembrance box outside each one containing medals and other special mementos. There is also a garden and a potting shed where patients have their own space for doing familiar tasks. Every day, carers like these devote themselves to improving the lives of others, and I think we don't often enough stop and recognize that. We also need to remember how it feels for people living with dementia and to make sure the whole of our societies are as supportive as possible, not stigmatizing those they can't empathize with.
You have to see through that diagnosis of dementia. You have to see the person, what they were, what they've become, and what we can enable them to do. What can they do rather than what can't they do?
Thanks to your initiative in Japan regarding dementia awareness, the UK founded the Dementia Friends program. There are now over 500,000 dementia friends in the United Kingdom. Canada has also now adopted the program. If this initiative can be spread around the world, imagine the potential in making sure our older communities are supported and understood. I turn now to the steps we can all take to reduce our risk of developing dementia. This is something that I and my colleagues on the World Dementia Council have been looking at in detail, bringing together the emerging evidence about risk factors. As a first step, I would like dementia to be added to the list of diseases and conditions people are less likely to develop by living well and keeping a healthy lifestyle, along with cardiovascular disease, stroke, and diabetes. We should embed them in national public health policies and strategies on non-communicable diseases. This is what gives me great hope for future generations. The trajectory of this disease doesn't have to take the path we expect. By working together on all of these areas, we can improve the lives of both those living with dementia today and stopping more people developing it tomorrow. Thank you.
ありがとうございました。昨日から始まった
Thank you. We have begun this legacy event in Japan from yesterday, and this is today and tomorrow. There will also be additional programs, but I hope that you will enjoy to the fullest these 3-day events so that we can firstly make the commitments step by step. Thank you.
ありがとうございました。
Thank you very much. So it was Dr. Kiyoshi Kurokawa. And I would like to invite Sir Mark Walpole, Chief Scientific Advisor to Her Majesty Government and Head of the Government Office for Science, UK.
Good morning. Minister Shiozaki, Professor Kurokawa of the World Dementia Council, distinguished colleagues, friends. It's an enormous pleasure to be with you here today at such an important event. As the Chief Scientific Advisor to the UK Government, it's a privilege to see so much activity cascade around the world as a result of those commitments made by our countries at the first ever G8 Dementia Summit in London last year. Before our eyes, global action against dementia is becoming a reality, with our countries working together to change lives. And I've had the great privilege of seeing this work grow over the past few years from the sort of germ of an idea to the global movement that we see today. In 2012, I was asked by Prime Minister Cameron to be one of 3 dementia champions working in the area of research. And those champions had 3 ambitions. The first was to create dementia-friendly communities that understand how to help. The second aim was to drive improvements in health and in care. And the third was around improving the research effort. And at the time I first became involved, I was the director of the Wellcome Trust, a global charitable foundation which supports research in biomedicine and the medical humanities with the aim of improving human and animal health. And so there was no better topic than dementia. And standing here in Tokyo today, there is really nowhere better I could be to be able to take stock of all that has been achieved since then in what is really rather a short time. And as a result of your long-standing commitment in Japan to care for and to respect elders in the community, you have led the way for others to adopt your community-wide approach to supporting those who need it. And as we've already heard, the figures are remarkable. Over 5 million people, about 5% of the population in Japan, have now completed their dementia supporters training as volunteer supporters for the country's dementia-affected population, with the aim to reach 6 million people by 2017. And it sounds to me as though you might get there even earlier. Given that 1 in 4 people in Japan is over 65, you've adapted to care for this growing part of your population in inspirational ways. And the circular support system that brings together people of all ages is something that we not only in the UK, but in the rest of the world can learn so much from. And we can also learn a great deal from your innovative technological solutions in caring for people with dementia and indeed older people more generally. And as we'll see later today, Japan is at the cutting edge of technological advancement. But crucially, you bring the creativity to turn innovation in technology into real-life care solutions. And as we've already heard from Dennis Gillings just now, the capacity now to bring loved ones and carers to be able to connect at the click of a switch by bringing robotic technology and computerized care systems into the home opens up huge possibilities of remote support and connectedness. And I think it's a very good example of how technology can help human connections. So it's not faceless robots, it's robots that actually enable the faces of loved ones to be brought directly into the room, wherever they are in the world. And of course, in the long term, not only is this good for care, but it may also be associated with cost savings and increased efficiency. And of course, one of the big challenges and opportunities is to keep people who have cognitive impairment in their homes for as long as possible. So in the UK, we have taken your lead on raising awareness and reducing the stigma around dementia. And in 2012, we adopted the Dementia Friends programme and now have over 500,000 dementia friends in England who have a much greater understanding of the condition, how they can recognise the symptoms and support people living in their community. And we're also working to develop dementia-friendly communities across the country, more than 70 of them so far, working to break down the stigma. And businesses, of course, are also an important part of this. And businesses from a range of sectors, including banking, retail, transport, have signed up so that their staff can support customers. And as the chairman of a well-known British bank put it very well, if my customer can't remember their PIN number, it's up to all of us to help. We owe it to them to support them through every step of the way. And of course, as we've heard also, the dementia-friendly initiative has now been adopted by Canada, who announced that they would become dementia-friendly at the last Legacy event in Ottawa in September. So if we can continue to spread the programme around the G7 countries, we'd make a huge step forward towards the commitment made by our health ministers collectively in December last year to call upon civil society to continue and to enhance global efforts to reduce stigma, exclusion and fear. And since that G7 Dementia Summit in 2013, there's been significant progress, not only on that commitment to reduce stigma, but also in research, working together to share information and to bring together academia and industry to turbocharge research efforts and be as innovative and creative as possible in looking for effective treatments. And the World Dementia Envoy and the Council have identified the key target areas where progress needs to be made in order to speed up the search for an effective treatment or cure to meet the 2025 deadline agreed by the G7. And as well as the work of the World Dementia Council, a number of other projects have taken off in G7 countries, including, for example, the Canadian Consortium on Neurodegeneration in Aging, launched in Ottawa last September, that brings together public and private partners. We've established the UK Dementia Platform, again, a public-private partnership with £12 million provided through the Medical Research Council and another £4 million provided by 6 UK and international companies. And overall, UK spending on dementia research is on track to reach over £66 million in 2014 and 15, and that's a doubling of the amount spent in 2009 and 10. One of the unusual features of the UK support system for medical research and care in the UK is the very strong charitable sector. And Alzheimer's Research UK and the Alzheimer's Society each have announced a £100 million pledge and commitment to increase their spending on dementia research over the next 10 years. So a lot of progress. But despite all of this, I think we all recognise the scale and difficulty of this challenge, so there is so much more to do. Firstly, we need to be sure that we bring all of the sciences to bear, the social sciences, engineering, technology, as well as the biological and physical sciences. Because on our latest estimates, the 44 million people living with dementia today are set to almost double by 2030. And we're going to have ever-increasing parts of our populations in need of care and support. And of course, it's not only those that live with the condition, but their families and their carers that need support. So this needs to be at least as much about the social sciences as it is about molecular biology. And of course, as I know from my own medical background, dementia is a difficult condition which we don't fully understand. Given that we don't understand the mechanisms of normal cognition, how we think, which is one of the great challenges of modern biology and medicine, it's very hard to understand all of the biology of the dementias. But it's also important to recognise that we can make a big difference and slow the onset of dementia by treating some of the factors that go along with dementia and accelerating it, like hypertension, high blood pressure, and managing diabetes. Because if we can do that, we can already make a big difference to dementia. So, Minister, Professor Kurokawa, ladies and gentlemen, our global action against dementia has made so much progress in just 8 months. But in order to reach that target of effective treatment or prevention by 2025, we need to continue and to sustain that action at the pace we have now, or we'll let down those people who so badly need our help. So we have 4 months left of this commitment and the clock is ticking, but let's make this a lasting commitment, maintain the momentum, and set our sights even higher. Thank you for your attention.
ありがとうございました。マーク
Thank you, Dr. Mark Wolpert. His Excellency Mr. Shiozaki, the Minister of MHLW, will have to be excused due to his official duty.
続いてのご来賓を
Next, WHO Director, Department of Mental Health and Substance Abuse, Dr. Seika Saxena.
Very good morning to all of you. My first words for Honorable Minister Shiozaki, who has just left, but I hope he does get the message, which essentially is from my Director General, Dr. Margaret Chan, who sends her greetings, but also WHO's commitment to the area of dementia, and would like to thank the Minister and the Government of Japan for organizing this event, for hosting this event, and also for keeping dementia a very high priority for the country. This is very obvious from the presence of the Prime Minister of Japan this morning with us. The theme for this event, New Care and Prevention Models, is especially relevant to WHO in the context of care today and cure tomorrow. Dementia essentially is a global issue, and the solutions also have to be global. There is already a very large number of people in the world who suffer from dementia. This number is going to increase as much as double in the next 20 years' time, and much of this increase is going to happen in low and middle income countries. So it is critical that countries all over the world recognize this as a public health priority and give it the attention that it needs. In this perspective, the initiative taken by the G7 countries is very much welcome, but it has to become global, and WHO will make its attempt to emphasize to other countries, middle-income countries, but also low-income countries, which are going to face the problem tomorrow, very soon, before this becomes completely an unmanageable problem. As you are aware, WHO is making a very serious effort on public health emergencies like the Ebola virus disease currently, and you hear it every day in the newspaper. But WHO cannot and will not ignore some of the other priorities that are ongoing. As opposed to the acute crisis of Ebola, dementia is a chronic crisis. It's a chronic epidemic. And efforts need to be made, and WHO will not ignore the needs of kind of illnesses that are represented by dementia. WHO's kept dementia as a high priority even earlier, starting from 2012, but the G7 initiative has further persuaded us to have continued action in this area. We have heard yesterday a lot of activities that are being done in Japan. We will hear more today, and it's very obvious that Japan has a lot of lessons to give to other countries, and we look forward to integrating some of those knowledge with the knowledge from other countries that are represented here and make this much more global than it is present right now. It is clear from yesterday's presentations that a systematic evaluation, including economic evaluation, is needed to enlarge our evidence base. For us in WHO, research is not only finding a new molecule to cure dementia, it is also about finding new methods of care or prevention. Indeed, when we talk about integrated development, it is not only about drugs, but it's also about integrated development of health and social services, and we certainly need more investments in research and evaluation in these areas also. For WHO, dementia also needs to be seen within the larger perspective of aging and other non-communicable diseases. After all, dementia is a non-communicable disease, and we'll continue to make efforts to provide technical assistance to our member states on these public health priorities. Lastly, I would like to mention that WHO will be organizing a global event on dementia in March 2015, and we look forward to seeing many of you there along with your ministers. Thank you very much.
ありがとうございました。シェイカー・サクセナ。
Thank you very much, Dr. Shekhar Saxena. Now, let me introduce the counselor of Alzheimer's Association of Japan, Dr. Shigenobu Nakamura, to give us a few words.
Ladies and gentlemen, welcome to Japan. As a counselor of Alzheimer's Association Japan, I often talk with many people with dementia. They can provide us many clues for prevention or novel cares of dementia. Current or previous informal family carers account over 90% of members of Alzheimer's Association Japan. Our association has continued activities such as Tsudoi meeting for 35 years with more than 11,000 members in every prefecture of Japan. Just today, several other members of our association are going to participate in Asia Pacific Regional Conference held in India, accompanied by people with dementia themselves, including Mr. Tanno, who gave a speech yesterday evening. Asian countries are supposed to have more severe problems of dementia in near future. Many productive maneuvers will be presented in this meeting, and information could be hopefully delivered to other Asian countries. Thank you for attention.
Thank
you very much, Mr. Shigenobu Nakamura. This Alzheimer's Association Japan has had this organization for over 35 years, and branches are across Japan, and in each prefecture at least one branch is there. So now there is an international movement for dementia, which is that people living with dementia themselves are communicating with the rest of the world and sending out messages. With that, I would like to introduce Ms. Kazuko Fujita, who herself is a person living with dementia. Thank you very much for your very kind introduction. I am Kazuko Fujita. I would like to speak about what I think and what I hope. And I am very happy to have this opportunity. In 2013, the Ministry of Health said that we need to create a community and a society whereby people living with dementia can continue to live with hope and safe and security. So that kind of dementia policy is now to be promoted. And I think this was a very big step for the people living with dementia. However, there is still much stigma against people living with dementia, and it's very much deep-rooted. Living with dementia, I myself feel such stigma in my daily life. People think that people living with dementia do not understand anything and cannot do anything. And this kind of deprive us of the will to live. And not only people living with dementia, but also their families are isolated in the society. After being diagnosed, they don't know what to do, and they are suffering. So I spoke to, I read a book written by Christy Ryden, an Australian person living with dementia. And I was able to meet with a lot of people living with dementia after reading this book. And even after being diagnosed with dementia, of course, I'm still Kazuko Fujita. How it feels like living with dementia, that is something I would like to tell to you. With much effort and with much concentration, I can still live a normal life. So people around me may not understand that I am living with dementia. So I have to suffer from this condition all by myself. But then sometimes I come to the limit, and I would like to say it's enough. And this is when probably I get some benefit from the long-term care insurance, but then there is a kind of a void or a gap between living with dementia without any support and finally being eligible to the insurance. This is a very important gap. This needs to be narrowed down. This needs to be completely eliminated in the future, because this gap exists, and this is a serious issue for everyone living with dementia. In this situation, October 11th, 11 people living with dementia in their 40s till 70s, they came up with a dementia working group in Japan. This is the first group in Japan which consists only of people living with dementia. We may not have a very big voice, but then by getting together and being united, we probably can join forces to make constructive proposals to change the world and change the society. So that's the purpose of forming this dementia working group. And then we were able to get an opportunity to meet with the minister, Shiozaki, and we made 3 proposals. And the minister said that let's work together, which was a great encouragement to us to materialize and cement our policies that we need to act ourselves. So people living with dementia, for our voices to be heard, we need to overcome a variety of obstacles such as a stigma and a non-understanding. Therefore, it's very important for us to have cooperation of the people around us and support. So we are all humans who would like to continue to live own lives. Therefore, we do not want to depend on the administrations and a variety of policies and supporters. We need to take initiatives. We would like to work together with people who are working on the issues of dementia. So that is the determination with which we decided to make this first step. Legacy event is being held in Japan right now, and this can become a trigger to ignite interest from more people. And I think this is an opportunity for people to get united from many different backgrounds. And I hope that each one of you considers this as your own problem, so that people living with dementia can all have hope and dignity. And once again, I'd like to thank you very much for giving me this opportunity. And I would like to thank other people living with dementia and their partners for giving me this great encouragement to be able to speak in front of you. And finally, I'd like to thank you all very much.
Thank
you. Fujita Kazuko-san is the co-chair of the working group. Once the working group was established, and then similar association members from around the world are giving the group the message. So they are determined to join forces with people with similar conditions worldwide. Thank you. This has been the opening presentation of the Global Dementia Legacy Event Japan. Thank you. I would like to prepare the stage for the next session, so please allow us some time. Those who will be presenting topic 1, please by 9:50 be gathered at the lecture waiting room. In the Sky Studio, and the latest exhibition of the robots, the Japan's proud robot technologies would open the door for dementia in the future. So please stop by and take a look. In the conference room, there are poster exhibitions as well as the exhibitions of the citizens' activities, including some videos. This is the #1 dementia country in the world, and what the citizens are doing, please utilize your break times to see yourself what they are doing. We'd like to go to the main conference. Please have a seat. We'd like to begin the main conference. Please have a seat. Now we'd like to introduce the speaker. OECD and Dr. Mark Pearson will be speaking on the title, Dignity in Dementia, How Policy Can Improve the Lives of People with Dementia. This is going to be the keynote address. Dr. Mark Pearson, the floor is yours.
Well, thank you very much. Konnichiwa, everybody. So, distinguished members of the World Dementia Council, Professor Kurokawa, and of course, the guests here today. It's my honor to be able to share with you some of the main messages of our reports, which I hope you all have, on how to improve care for people with dementia. And it's been prepared by my colleagues at the OECD, but with close collaboration with our great friends from WHO, for which many thanks. Thank you, Sheka. For while cure must be our long-term goal, we cannot, of course, ignore the needs of the 50 million people globally who have dementia, soon to be rising to 80 million. So what we have in our reports, let me very briefly run through the case for policy action. I don't need to persuade, I think, this audience that there is need for action, but maybe it's worth recalling some of the evidence on the size of the problem that we face. This is evidence from the WHO on the global burden of diseases, and dementia is the fastest growing cause of disability in the world today. So the diseases towards the top of this chart have the biggest burden of disease, but the ones towards the right-hand side are growing more quickly. And so you can see at the moment, dementia is not a huge issue in terms of the size of the disability, but it's growing far faster than any of the other sources of disability. And of course, when we look at the over 70s, we find it's already one of the biggest causes of a burden of disease and is growing incredibly rapidly. What that means, of course, when you combine it with population aging, is very large increases in the number of people who will have dementia in coming years. Here I've shown the proportion of the population aged over 80 in different countries. And you can see, even as early as 1990, Japan was actually the youngest G7 country. And yet, by now and in the future, it's the super-aging society where we'll be reaching 14% of the population aged over 80. What that means in practice is that we're having a 50% increase in the prevalence of dementia every 2 decades, an incredibly rapid increase. And that, of course, adds up to money. I'm from an economic organization. Forgive me if I do occasionally mention things like the costs of dementia, because they're very large. What we've done here is to gather together some of the estimates of the direct costs, in other words, the health and long-term care costs due to dementia, together with the indirect costs, people not working either because they have a dementia or because they're caring for somebody with a dementia. And you can see we're talking about very large amounts of money already, even though most of the increase in dementia is still to come. And if we look at the global estimate of the costs of dementia, $650 billion, or if you like, roughly the GDP of Switzerland or of Denmark and Sweden added together. That's already before the big wave of disability due to dementia really starts having an impact. So we have lots of reasons why we must be acting on dementia. The large human cost, of course, is the most important reason, but there is also a very large financial cost that our economies and societies must be coping with. So the main focus of our report is what we know about how dementia policy can be improved. And of course, the main responsibility here is that, well, there are good examples of good practice across the world. The real issue, I think, is that good practice is often not replicated widely. We've heard lots of references already to the fantastic Dementia Friends initiative that started in Japan and is now spreading across the world. We don't have enough examples like that. Dementia policy is taking place in national silos, and I think one of the great successes of this G7, G8 initiative is to spread that conversation globally about how we can learn from each other's practices. And the OECD and the WHO want to work together in order to help you do this. The main focus, of course, is going to be on what happens domestically. We need a cycle of testing, evaluating, measuring and benchmarking and implementing policies so that we can learn from what is working. And of course, the renewed focus on research must involve people with dementia and their families much more than has been the case up to now. That's what needs to happen in order for effective policy. But international efforts can actually help you in doing this. We can identify key priority areas, which we've tried to do in this paper, look at the policy options and evidence for what works in each of those areas, and absolutely crucially, try and develop metrics, ways of measuring what different countries are doing and how effective their policies are. And indeed, my biggest hope for this meeting is that we come away with it with an agreement that we must work together to develop international benchmarks for how we're doing on dementia policy, dementia care. I think if we have international agreement on what we should be measuring, then we'll be able to make progress much more rapidly. Now, of course, we're not going to get agreements at this conference, but if we can have agreements on the measures, but if we can have agreement that we should be working on developing the measures, I think we'll have made a huge step forward. What we do in the paper is identify 10 key objectives for dementia policy. And in each of those areas, we've had a first go at looking at what should be measured. And those 10 areas, very briefly, I'll run through. Prevention, diagnosis at an appropriate stage. Then for people with early dementia, creating dementia-friendly societies, and for supporting informal carers. For people with more advanced dementia, we look at making sure that there is an appropriate care environment, that formal care services are of high quality, and that care for other health needs is done in a satisfactory way. For end-of-life care, we think that we should be looking at whether appropriate care is being provided. And there's some cross-cutting issues, the coordination of care between different providers, and of course, the role of technology. They're the 10 areas where I think we can and should be developing measures of how we're performing in each country in developing good dementia policies. I don't have time, of course, to go through all 10 of those areas. Let me focus very briefly on just 4 of them. And the first one is on making sure that we have timely diagnosis. I think the issue here is that obviously people with advanced dementia we want to make sure have been diagnosed. They'll benefit from, there's a good therapeutic case for making sure that we have an appropriate diagnosis. There isn't any good therapeutic case for pre-symptomatic screening as yet. Now, this may change if new treatments become available, but we don't want to be running population-based screening on dementia. It would cause more anxiety than is than the benefits would justify. So the area that we need to focus on is people with mild symptoms. Are we actually diagnosing them appropriately? I think the evidence is pretty strong that if people are concerned about symptoms and seeking a diagnosis, then even a positive result, saying that yes, they do have dementia, can reduce anxiety, and so the positives outweigh the negatives. And this is broadly reflected in country policies. You know, in France, patients are provided with the opportunity for diagnostic testing, but they do have the right to refuse. Netherlands, again, people entitled to testing, but not actively promoted. If that's the objective, how are we actually doing? And the answer is not particularly well. Fewer than half of all people with dementia in England have a diagnosis. When we look in Germany, we find that that's a similar ratio. Only 44% of care home residents with dementia. There's 44% of them have no diagnosis. So I think that we're a long way from where we need to be in ensuring that people with dementia are diagnosed appropriately. And we do know that policy can make a big difference here. If you look at what's been happening in Scotland, for example, where they went from a very low rate of just 40% of people with dementia being diagnosed, right up to 67% now in the matter of just 4 or 5 years. That's a very impressive achievement. So I think there are clear metrics that we can be developing that we can use to check how we are doing across countries and whether we are performing as well as the people with the good practice, the best practice. Second area I want to look at is supporting informal carers. And, you know, most countries have been moving towards more community care. Not necessarily particularly rapidly. The little black dots here are the number of people who are living in the community and yet receiving care in the year 2000, whereas the bars show the current state or the state in 2012. And there's been an increase in most countries in line with national policies, but it's not been particularly rapid. Of course, the reason why we promote this is that we believe it can lead to a better quality of life if people are cared for at home, and possibly also it may be cheaper to do so. When we actually look at the policies that are in place to support informal carers, we do find, again, a lot of problems and a lot of things that maybe we should be measuring more to understand how well we are doing. For example, respite care is increasingly provided to support informal carers. But when we actually look at how it's used, we find that many people do not take advantage of this care for various reasons. But nevertheless, I think that's a very good case for why we should be measuring this more carefully and understanding what are the reasons why people aren't using the services available to them. Counselling and support, of course, is very important, and I'd like to draw attention, as we do in the report, to the English Dementia Carers Support Service, which links current carers with former carers. I think a very valuable initiative. Help with people who are in employment. Of course, if you have to care for an elderly relative and you have a job, that's a problem, or it certainly can be a problem. I think Germany has been very innovative here with its policy to allow you to reduce hours but to maintain your salary in return for, in the future, having a lower hourly salary rate but working for longer in order to be able to buy some time so that you can actually support a family member. And information and training, of course, is very, very important and draw attention in our reports to the policy in France to allow people who have dementia caring responsibilities 2 days of training per year. So I think there's a lot going on in informal care that, again, we can be measuring and looking to see what works. Third area I want to draw attention to, and a particular topic which is, I think, concerns me very much, is how we manage people with dementia when they have other health needs. People with dementia are 2 to 3 times more likely to be admitted to a hospital. When they get there, they stay, on average, twice as long as people without dementia. They're more likely to be readmitted quickly to hospital. They cost, as a result of those 2 factors, nearly 3 times as much for the same diagnosis as somebody without dementia. And yet, when we look at what happens to people with dementia in hospital, we find some horrifying statistics: 15 to 30% developing some delirium, a third losing functional ability whilst they're in hospital. And these things persist. Even after 6 months or even beyond that, people's poor functional ability and delirium is not recovering. So hospital care, we can't help but conclude, is poor for people with dementia at present. There are initiatives going on, which I think we, again, can be learning from: information sharing, consistent recording of diagnoses across different parts of the care system, consultation and liaison services in order to provide appropriate care, reduce the risk of depression for people with dementia, and specialist wards, which I think have been having some positive outcomes so far as we can tell from the evaluations. There are examples of good practice. I mean, I'd like, again, to draw attention to the great example in Ontario of geriatric emergency and management nurses in hospital emergency departments to identify, assess and work with people, with frail elderly people. I think that's a fantastic initiative. And what's happening in the UK to develop dementia care pathways, and having 3/4 of UK hospitals now having dementia champions. So again, I think there are some interesting initiatives going on that we must evaluate, and if they work, spread more widely across the world. Last area I want to talk about, of course, how could I not, in Japan, talk about the role of technology for improving care for people with dementia. Lots of promising examples of how technology can improve dementia care, but we have to face the fact that it's not yet very widely used. I mean, we have some great examples of promoting social interaction. Everybody knows about the Pera robot, and that is now, of course, being subject to a randomized clinical trial in the Netherlands. Automatic dispensers to reduce medication error, telesupport monitoring services such as the Comfort Zone in the United States to cope with wandering issues, and mechanical lifting devices to reduce the risk of injury. Lots of initiatives going on, but they're not really being widely used. Now, why is that? I think there's 3 key barriers to the development of care technologies. The first is the type of technologies that are being developed. We don't really get as much user-focused development as we should. I think some of these technologies are designed for technology companies, not for people with dementia. And I think we need to find ways to get the needs of people with dementias much more involved in the development process. But more than that, I think we need to evaluate the effectiveness of new technologies much more effectively than we currently do. There are not enough robust trials of new technologies going on, not in the way that we do for new pharmacological products, for example. And this will give the confidence for care systems to actually use new technologies more widely. But this third issue about clear reimbursement criteria, I think, is also very important. Most care systems do not have clear, transparent criteria for how they will actually pay for new technologies. So why should they be developed? I think we need to find a way of giving manufacturers the confidence that new technologies will be actually bought by caring institutions. And that means that we must have much more clear reimbursement criteria. Ladies and gentlemen, I've spent a lot of time talking about the need for measuring performance, and I'm going to actually say this yet again. Improving the measurement of dementia needs to be a priority in any international efforts. We have very few internationally comparable measures of dementia outcomes and the impacts of policy. We need to do that much, much better than we currently do. And I hope that this event provides an opportunity to continue that conversation even more. I was very encouraged yesterday by the number of questions that we actually got from the floor about when people talked about their new care models, people asking, what were the evaluations? Can you actually demonstrate that this was effective and cost-effective? I think that they are the right questions to be asking, and we must build a system internationally to make sure that we can answer those questions better than we currently do. There are some key enablers to make sure that we do that better, improving diagnosis rates, consistent identification and coding of dementia in health facilities, possibly even dementia registers, as already happens in Sweden. Or if not, then we make sure that we can link data across health and care systems using electronic health records. In terms of the actual measures, we've made some suggestions in our paper, the measures that we would think are possible over the next 5-10 years to develop internationally comparable indicators across countries. Obviously, that's to start the conversation. We expect much more work, much more consultations on how we can refine this list and build consensus internationally over the coming years. So let me conclude. We need an international framework for understanding performance and holding each other to account for the improvements that we can make in dementia care. We've argued that there are 4 key elements that will enable this to happen, that we have to agree a set of objectives for dementia policy against which we can be assessed, that we develop evidence on which policy approaches work and indeed what is going on across countries, that we develop international metrics to measure overall performance so that we can say where countries are doing well and doing badly in their dementia care, and develop these enablers for measurement, such as electronic health records. So we need to start, we need much more work, we know, on how to develop this framework. We look forward to working with the WHO, ready for the March event, the final legacy event of the World Dementia Council, and we need to start a conversation there so that at that event, I hope we can start coming to agreements about what can be achieved internationally. I thank you for your attention. Thank you.
Thank you, Dr. Mark Pearson, for the keynote address. We have WHO Director, Dr. Sheikha Saxena, will make the comments.
Thank you very much, Mark, and your colleagues, not only for preparing an excellent paper, but also presenting it well. Mark, I'm admiring you. So, Mark, I was saying thank you very much for the excellent paper prepared by you and your colleagues, and also presenting it very well. We have had the possibility to provide and push the paper, so I have not much to add to that. I have 4 comments to make. The first one is the paper is about policy options. And one of the more important things here is to actually remove the pessimism around dementia. Clinicians think many times that not much can be done. And similarly, policymakers many times think that it's a large burden, but nothing much more can be done. And that pessimism needs to be removed. policy options, as the paper very clearly points out, do matter. There are choices to be made, and the cost of inaction is very high. So that's the first message which I get from the paper, that there has to be a message to policymakers that you have a responsibility and your actions will make a significant difference to how the burden of dementia in future is tackled more effectively and more efficiently. Second comment, policies need to be developed with the involvement of a larger number of and variety of stakeholders. Policies have been made in isolation, without adequate consultations, and in closed door environment. That is neither the most efficient method nor is an effective method. So many more stakeholders need to be involved, which includes not only various departments and ministries within the government, but non-governmental organizations, civil societies, and very critically, people and families affected by dementia. And that is a message that comes out again very clearly from the paper, needs to be emphasized to everybody who is trying to make a policy. Third comment, what are the next steps? This paper is obviously in preparation. There'll be need for your comments, so feel free to write to OECD and WHO with your comments, which will be very welcome. But the next step is to make the policy analysis wider, that means involving more countries, and deeper, involving more data and more examples. And we are very happy to assist OECD in doing this, to make it wider in terms of geographic and other distributions of countries, going beyond G7, going to OECD countries, going to the WHO's membership, that is all the countries, and also making it deeper in terms of trying to analyze more examples, getting more data, and looking through more information so that we can come out with better conclusions. So that's the third, in a way, commitment that we can make from WHO. How can WHO help further? By analyzing it more, but also by making it a more continuous exercise rather than an ad hoc exercise. One has to begin sometime, and it's a good beginning, but one has to make it really a continuous process where we keep collecting the data and doing analysis on a basis which is regular and is continuous, so that we can derive the information that is the latest and do the analysis that is up to this time, which means ongoing collection of data and ongoing making of policies. That's the job of OECD and WHO mandated role, and we are very happy to do that. So with these 4 comments, I thank OECD again for their preparation of the paper, and thank you for your attention on this. Thank you.
Thank you very much. Thank you very much for your excellent keynote address. And we would like to move on to the next session. Now, we'll have different topics. Now, yesterday, there are 4 different subspecialty meetings, and I'm sure that a lot of you attended different sessions. Now, based on yesterday's discussion, we will have the meetings based on the different topics. Dr. Mark Pearson talked about differences in different countries, but it's very important to create the international framework, and the international collaboration is important to work toward creating an international benchmark. So when you attended the specialty meetings, you must have understood the differences in different countries and differences in different policies, characteristics and cultures, and you must have learned the best practices from different countries, and also you must have learned that some of the practices that you are doing in your country, they excel the activities in other countries. So again, and that based on yesterday's discussion, I'd like to move on to the topic 1. So we had a theme yesterday, dementia in community, timely and appropriate prevention and care. We would like to discuss this today again. So commentators and also the presenters, are you ready for the topic 1?
この後、今日は本会議を通じてですね、それぞれ
Throughout the day, we have a discussion based on yesterday's meetings.
それではご登壇の皆さん。
I think we're ready to welcome all the commentators and presenters. Topic 1's the chair is done by the Dr. Yves Janet of the Institute of Aging, CIHR, University of Montreal, Canada.
I would like to welcome everyone to this session on dementia in the community. And we will have a number of speakers. However, we will also connect with the very rich discussions we had yesterday. And in order to start and refresh our memory with regard to the discussion we had yesterday, I would ask first the co-chairs of the session 0 yesterday, Kenji Toba and Christian Beringer, to provide us a short summary of the discussions yesterday.
Yes. So slide, please. So in the session,
Okay.
different conditions are reported from the G7 countries, but which have a shared point from 1 to 7. First, dementia is a big challenge in all countries, and the challenge contains establishing care system and educational programs of professionals, including general practitioners, and also dementia at home. And fifth, dementia-friendly communities, essentially important. And sixth, coordination of effort, not only from the professionals, also the family. And seventh, to achieve or to overcome these challenges, international collaborative research and exchange the knowledge is very important. It is a shared point of session 0. I asked to the co-chair, Mr. Beringer, the comment of this point. Okay.
Please, Dr. Beringer, some comments as a co-chair of this session. Thank you.
Yes, thank you very much. These shared points, of course, they are points that were leading from the experiences and policies in the G7 partners to a common ground and a shared momentum. And I want to point out a few key words that go back to the 7 points we have just seen. When we talk about dementia challenges, we talk about the keyword strategy. So there's a demographic change going on, and towards demographic change, all the countries are striving to enhance the ability of societies to cope with the tasks of care and cure and to tackle dementia. And when we talk about, we can't see it again, establishing a care system, the key word, I think, which was talked about yesterday was coherence. So different levels and professions have to work together, and different points of action are to be seen together. Prevention, rehabilitation, home care, care homes, all belong to one system of a care established system. And if it comes to the education, the third point, education of professionals, it is about knowledge, and it's knowledge creating and knowledge sharing from professionals to non-professionals and between professionals we talked about. And this, of course, means information and also fighting stigmatization. And the fourth point was dementia at home, and this means individuality and accessibility in the sense that we have families which need to have access to different and individually adopted forms of help by persons, by institutions, and by structures. So we have to combine case management and care management at that point. And this leads to the fifth point. Kenji talked about dementia-friendly communities, and there the key word would be inclusion, which means care is not only in the family and not only in care institution, but care is within the society and within the neighborhood. So we talk about everyday life and inclusion in everyday life. And if it comes to the sixth point, coordination of efforts, it's about programming and agenda planning, which happens in all the G7 countries to some extent. And it's national pathways we have seen and heard about, which have started from the ground with different qualifications in different institutions and different levels of action, and which are now brought together in national plans, dementia plans, agendas, different nominations we have heard about. And now we come to the 7 points, collab internationally. This is the global action, the momentum we are working at. I don't have to elaborate on that. And thank you again for listening to me.
Thank you, Kenji Toba and Christian Beringer, for this summary of session 0. I will provide a very short summary of session 1 yesterday, again, because it's important to have the summary of what we discussed yesterday with Dr. Hasegawa. So I will first provide a little bit of... So session 1 yesterday, and if I could have the slides, was on timely and appropriate prevention and care. And one thing we heard about was the concept of prevention and the importance of promoting prevention, of including, and in fact we heard that in most dementia plan promotion was really embedded in those plans. In my mind, prevention here, however, refers to at least three levels, because there's the prevention of the neurodegenerative diseases itself. And we saw, for instance, vascular health as being contributing to preventing the cascade of events leading to neurodegeneration. But there's also prevention of the neurodegenerative disease to induce dementia. And this is a notion that is frequently referred to as building cognitive reserve in order to face and compensate the impact of unfortunately, a disease there, but its transformation into dementia. And the third level would be, well, even if there is dementia, there is a neurodegenerative disease, it's also the prevention of the dementia to interfere with social participation. And we heard lots of this yesterday. So prevention is, in fact, a multifaceted concept. And it reminded me, Dr. Saxena from WHO, of the CFI and handicap model, where, in fact, we have these three levels already embedded in a framework, and that we could have probably a better conceptual approach to the whole challenge if we would, inspired from work that goes back to the 1980s, balancing between addressing the disease and addressing the social participation, for instance. We also learned about early and timely diagnostic, and we learned about the advantages and the disadvantages of early detection, the necessity of early support, and I was really impressed with some of the Japanese program in there, the ROCN facilities to support and provide intensive, tailored rehabilitation, and tools to support the general practitioners as well, and we heard lots of those examples from Japanese colleagues. Then we heard different models of care, And each of these cares were specific to dementia and integrated the community-based system, also alluding to some hybrid model. And I would say that we heard lots about the Orange Plan, the Kumamoto model, the UK hybrid approach, as well as the specialized center-based model in France for early young onset dementia. Some participants insisted on the fact that there should be a balanced approach between efforts to cure, delay, or modify the course of the disease on one side, and to offer social inclusion and adaptation, and this is very important. Finally, I think that the session yesterday really underlined the unique opportunity to have more collaboration between G7 and beyond countries, including low and middle income countries, in order to compare, evaluate all these plans, because the notion of evaluation was really in the mouth of everyone yesterday. Among the points discussed, the costs, were highly discussed, and the financial and the balance between the financial and the social and quality of life aspect and the necessity of the economic evaluation was also very much discussed. So this was, for those who were not there yesterday, what happened in session 1 and will be fed into the discussion. But I would like maybe to ask Dr. Hasegawa to maybe make some comments as he was co-chairing with me. Please, Dr. Hasegawa.
Good morning. My name is Hasegawa. As was mentioned, I was serving as the co-chair in yesterday's session 1. I have received lots of information which I'm very thankful about. Other than that, I have 2-3 comments that I would like to make. Already, the MHLW, the ministers are already doing, but there ought to be the Dementia Bureau to be established within the Ministry of Health, Labor and Welfare, or within the government offices. We have the vertical integration, but horizontal integration would be needed. And that is why, in order to avoid working in silo, we want to have that sort of the Dementia Bureau within the Ministry of Health, Labor and Welfare, or within the government functions. The second comment is about the caregivers, and we need to foster the professional caregivers, which is important. And I also belong to the Institute Tokyo Dementia Care Research and Training Center. There are 2 centers in Tokyo and 1 in Aichi Prefecture, and we divide the country into 3 regions so that we can foster the nursing care professionals for dementia, who would serve as the leaders in dementia care. And in the past 1 year, we have had several committee meetings, and we have discussed about the policy recommendations to the government. And we wanted to establish the outline, and the outline ought to be distributed, and that's exactly what we are doing now. That's sort of the attempt. Will not be only limited to local actions and local efforts, and we also honor the differences in regions within the country, but we want to have the basics, the fundamentals. So that was why we wanted to establish the committee to discuss, to make the policy recommendations to the government. It will not be only in Japan, but can be already done by other countries as well, which is a wonderful effort. The third comment I'd like to make is the creating the dementia-friendly society and the community, and that would be the ultimate goal. There are many city planning, towns planning, and the villages planning. We can tap the existing local resources. That is why we first began with local mapping. Where are the GPs who can look for the dementia, and where are their care houses where the people with dementia and the families turn to? So that's sort of the mapping we began to create. We had the great East Japan earthquake and tsunami, and there was a huge tsunami engulfed the coastal regions. I do not remember the exact number, but in town, 2,700 people living in the village. However, the tsunami engulfed the village, and there were many people who were swallowed and swept away by the tsunami. But junior high school and high school children ushered those people with dementia, and these children guided these elderlies to the higher place, and all of them survived the tsunami. That was a wonderful story. So that was a success story of giving the education to high school and junior high school students. And together with the Ministry of Education, that was exactly what was happening, and it's still happening, which is very important. And this is all I have to say. Thank you.
Thank you so much, Dr. Hasegawa. So after this summary of the discussions of the experts yesterday, I would like now to invite Jacqueline Heugendam from the Ministry of Health, Welfare and Sport from the Netherlands to tell us her point of view on this question, and particularly the reform in Dutch long-term care. Thank you, Jacqueline.
Yes, thank you very much. I'd first like to say I feel very honored that the organization asked me to present the reform in Dutch long-term care and the positive effect it will have on dementia care. I'll tell you about how to create a sustainable long-term care system without decreasing care and at the same time increasing quality of care and quality of life for patients, including those suffering from dementia, and to increase social involvement of all residents. For the past decade, we were confronted with a seemingly uncontrollable increase in cost of long-term care, an unsustainable system in the future with increasing numbers of elderly people and decreasing numbers of working people, which is not unfamiliar to other countries, for instance, Japan, as we heard yesterday. And dementia is one of the most expensive illnesses in long-term care, so we had to do something. So after our first dementia plan, which started in 2004, in 2008, the Minister of Health introduced a second national dementia plan, which was focusing on cooperation between all professionals in dementia care and providing coordinated care from the first symptoms of dementia until disease. And this includes early recognition by professionals and a focus on GPs who have to be attentive to the possibility of a patient having dementia. We also included a biannual measurement of the network's performances, and we aim to improve the guidance and support for the patient and its relatives. By 2011, in almost all of the Netherlands, coordinated dementia care was available, and all networks offered case management, which started from the first symptoms of dementia or from the diagnosis. This depended on the network. By 2013, this coordinated care proved to be cost-effective and to improve both quality of care and patient satisfaction. And in the same year, all professionals involved in dementia care, so from nurses, doctors, medical specialists, social workers, etc., agreed on a dementia care standard, which is a description of all the necessary care from the first symptoms of dementia till the decease of the patient. Now, this coordinated dementia care was used as an example for reform in the entire long-term care in the Netherlands. Up to now, we have a big Exceptional Medical Expenses Act, which is publicly funded, and a small part of a welfare act for municipalities, and CURE is embedded in private health insurance. The reform consists of three parts. First, we introduce more tasks for municipalities regarding those living in their own homes who need care. For instance, support for the patient and the informal carer combined with daycare and respite care. And we also introduced the activities of newly established social teams in the neighborhood who have to work together with community nurses who will have extended tasks. and all will be organized close to home according to patients' needs and wishes, and it has a public funding. Second, home nursing, which is now part of the Exceptional Medical Expenses Act, including case management, will become part of private health insurance. And third, for those who have a lifelong dependency on care in nursing homes, we'll have a new Long-Term Care Act, and this act will also introduce a more important role for informal carers while their relatives are in a nursing home. But as an extra, we will give a legal foundation for providing nursing home care in your own home if you wish to. So you can move the nursing home to your own home and stay there, provided your social network is up to it to be active in that kind of care. All these reform acts will become effective from January the 1st, 2015, and the preparations and actions in advance of the introduction are promising. Well, people with dementia will profit from this reform even more, although it was an example for the reform, and now the reform will help dementia care. First, important tasks of the care provided by the regional networks for coordinated dementia care will have a legal foundation, because for the past years they sometimes have been struggling to offer the coordinated care which was not according to the rules we had. And perhaps in future we'll even have integrated payments for care, so not the three systems, but one amount per patient per year. Second, there will be more attention to social involvement of all residents, resulting and contributing to a dementia-friendly society and helping the patient with dementia to remain a full member of society. In the third place, we'll accept less burden for the informal carer, as there will be more help from neighbors and volunteers, but also professional support provided by the municipalities. Fourth, we expect more involvement of municipalities for leading to more tailor-made care, more patient satisfaction, and better quality of life. And last but not least, the reform will be leading to more coordinated care besides dementia care, which will be very important for people with dementia as well. As you know, most people with dementia have other diseases as well. So the expected results from the entire reform of long-term care will be a sustainable long-term care system, an increase of quality of care through more coordinated care, care organized closer to home, more involvement of informal carers and volunteers both at home and in nursing homes, and more tailor-made solutions for the patient. And last but not least, an increase of quality of life for all people dependent on long-term care, especially those with dementia and their relatives. And thank you very much.
Thank you, Jacqueline. We will have a discussion and questions from the audience at the end of the session, so we will come back. And thanks, Jacqueline, for the perspective of the ministry, the policy makers. I would like now to invite Jeremy Hughes from the Alzheimer's Society UK to provide the perspective of the users, those living with Alzheimer's disease and the caregivers in this question. Thank you.
Thank you, and thank you for the opportunity to address this very important summit that the Japanese government have taken the initiative on bringing about. It is a very key moment for global action on dementia. So, as you already heard this morning from Sir Mark Wolpert, the Alzheimer's Society is making a major contribution, contributing £100 million to research, is taking the Dementia Friends programme across the country and developing dementia-friendly communities. But what I want to talk about briefly this morning is the core of our work, which is the local activity that we have with people living with dementia in their community. We have 3,000 local groups operating across the country. We have a internet-based social chat room for people with dementia with 30,000 participants. We run the helpline and the information service in the UK. And the essence of this is the statements that people with dementia themselves have said they want. This is the National Dementia Declaration that was adopted in England in 2009, and it was based on research from people with dementia as to what it is they want in their everyday life. How do they want to live? And you will see in these statements that they all start with the word I. So they are personal statements about how I want to live as somebody with dementia. And none of them are very exceptional. They are all things that we would all want to have in our everyday life. And so our starting point is saying that the support for people with dementia and for their family caregivers is to enable them to participate in society and to live as well as possible with dementia through the journey of their disease. I thought it was said very well by Kazuko Fujita, who spoke in the opening session this morning, when she said, after being diagnosed, I am still Kazuko Fujita. She is still the person, and people need to see the person, not the disease. But of course, she made one big assumption in that first statement, which is that she had been diagnosed. And so the starting point for us is to make sure that people are able to get a diagnosis. This map shows you in colour across England the difference in the number of people getting diagnosed with dementia. So green is above average, red is below average. And you will see that it is not a uniform picture across the country. Indeed, we still have a situation where in England only around 53% of people with dementia get a diagnosis. In Scotland, as my colleague will say later, it's more like 70%, and the commitment in England is to reach the Scotland level by March or April of next year. So there's a big programme of change. But it is really unacceptable that we have a disease where people are living with a disease without a diagnosis. In the UK, I suspect in Japan, in other countries, if cancer was the disease you had and you died from a cancer tumour before it was diagnosed, people would say that is unacceptable. But we have accepted the fact that you can live with dementia and die with dementia before anyone is diagnosed. That needs to change. So the programme is about looking at how you bring about that change and what is the perspective of people with dementia. And everyone I have spoken to, without exception, has said that whilst they don't want to have Alzheimer's disease or another form of dementia, they are better knowing that they have the disease and being able to plan their life accordingly than not knowing. We had a woman with dementia who spoke to the World Dementia Council last month, and she said it took her 6 years to get a diagnosis, because every time she went to see the doctor, she was an intelligent person and she was able to pass the tests. She could remember who the Queen of England was. She could remember what the day of the week was. And so he kept saying, there's nothing wrong. But she said, I knew there was something wrong. I knew my mind was not working in the way I wanted it to. And it was only after 6 years that she had an MRI scan and it was shown that she had amyloid plaques and she had the development of Alzheimer's in her brain. And she said, at last I was able to know what was wrong with me and to manage my life. So the focus of our work is working with primary care to increase the awareness of family doctors, training programs, because historically there's been very little training for family doctors about dementia. And they still have a very medical model, which is that you shouldn't diagnose people, often people are saying, unless there is a medical intervention. Now, most doctors now are changing their mind, but there's still some who feel that. We must realise that actually enabling people to live with their disease is as important as clinical treatment. But it's not just the family doctors, it's also the health centres that the doctors work in. Because the visits that people with dementia and their family caregivers have to the doctor are often very short visits around a specific disease. I have somebody I know who has dementia, and they have a closer relationship with the receptionist at the doctor's practice than they have with the doctor, because they spend more time talking to the receptionist. So we need to make sure that everybody in the health centre understands about dementia. In my local health centre, they've now got a system where you electronically register that you have come to see the doctor. So there's a keypad and you enter your name and your date of birth. That means for someone with dementia, you are stopped at the door because you cannot do that. So we have to think carefully, and this is a context for today's discussion, that we use technology in an appropriate way that enables people with dementia rather than disables them. And as well as the health centres and the family doctors, we also need access to the specialist advisors. And some of the most exciting programs in the UK is where we are bringing the specialists to work in the local health centre, in the family doctors, because it's much better for someone with dementia to see people in an environment they are comfortable with, rather than being sent to a hospital where it might say a big sign saying mental health hospital, you see people you don't know in an unusual environment, the whole thing becomes very distressing and very difficult. So we want to bring that specialist support back into the family doctor setting, and indeed for the GP, the family doctor, to have more training, as I said earlier. But post-diagnostic support is also vitally important. It's no good diagnosing people and then leaving them. One woman I spoke to recently said she was diagnosed and the consultant said, I will see you in 6 months' time. And that's the only support they got. Well, when you are diagnosed with a disease, you don't immediately have all the questions in your mind, particularly if you have dementia. These come to you and to your family caregiver in the middle of the night the following day, 2 weeks later, 3 weeks later. So one thing we've produced is this dementia guide. This is now being produced by Alzheimer's Society, but with the support of the Royal College of GPs, the Royal College of Psychiatrists, the Association of Directors of Adult Social Services, and the NHS. And every person, when they're diagnosed, gets a copy of this book. You keep it on the mantelpiece, you keep it on the shelf at your home, and you can refer to it, and it tells you where to go to look for support. It's very simple, it's not high tech, but it's a way of giving people access to information and guidance and support. And we're now into the print run. We've now produced 250,000 copies of this book. So everyone who is now getting diagnosed is getting a copy of this book. So those are the main areas that I wanted to introduce, that there's a need to recognize that we should listen to people with dementia, and people with dementia want to know that they have a disease, and they want to know how they can live well. We need to educate the family doctors, the people working in the health centres around them, and bring the specialist support closer to the environment where people are. And we want to make sure that there is the support after diagnosis that enables people to live well. The dementia guide, the dementia advisors that we provide, the other forms of support. Thank you very much.
Thank you so much, Jeremy. And I think it certainly addresses, after the long-term care first speaker, some of the responsibilities and actions to be taken vis-à-vis early identification and support. And we'll hear now from Scotland, and I would like to invite Jeff Huggins from the Health and Social Care Integration in Scotland, a complementary perspective on this question as well.
Eve, thank you very much for the kind introduction, and I'm very pleased to be here today in Tokyo representing the Scottish Government. Konnichiwa.
Good afternoon.
Thanks. I'd like to thank the partners who've organised the event and the Japanese government. And I think we're privileged to have so many people here today who care so much about dementia. So, thank you. We do great work in Scotland on dementia. It's been a national priority since 2007. And some of our results, and some people have been very kind to us already today and talked about them, have demonstrated just how much you can achieve in a relatively short period of time with political will. As you can see, we've significantly increased diagnosis rates, and that stops, but the line continues on in pretty much the same way that it's going at that point. In Scotland, I should be clear that things don't always work well, that we have challenges with the services that we deliver, that sometimes we have deficiencies of care, and we like to be open about that. We like to see that when things don't work, that's an opportunity for learning. But yesterday, when we were hearing from many of the national representatives and others, we heard very much about the challenge. We also heard what people were doing. But there were times when I thought yesterday that we didn't understand just how much was being achieved by people working in dementia at the moment. And because the ambition that we have here it's an enormous ambition. It's an ambition to transform care over a very short period of time. And the work that's going on across all of the countries, and Japan is a leading light in that, is just remarkable. But today I've decided I'm not going to talk to you about Scotland. I'm not going to tell you what we did. I'm going to be very happy to welcome you to come to Scotland to learn about what we did on diagnosis and on other things. And I'll be very happy to share our learning. What I'm going to do instead, so I'm sorry for that. What I'm going to do instead is I'm going to think a bit about if we were thinking about design principles for care, if we were taking a step back and thinking about what are the ways in which we would want to take forward reform, what would those principles be? Because I think there's an opportunity to think across countries and across organisations about what the fundamental ideas here might be. And so I'm going to suggest 3 design principles to improve the quality of care, and I'm going to ask for your views on what you think they should be. I'm going to ask you to tell me, but I think you should also tell the World Dementia Council, the OECD, the WHO, and the European Union, and indeed your national governments and associations. So if you're tweeting, here are some people who you can give your views to, and an easy method as we go along, but if you're not, there are other ways to communicate. So the first principle which I've set out is what I've described as the humanity principle, that care and support is offered to people with dementia and their families and carers in a way which promotes well-being and quality of life, protects their rights and respects their humanity. To us, it is unacceptable that too often the experience of people does not meet this standard, even in Scotland, where we are proud of what we do. People with dementia tell us that they want to stay at home, that they want to stay part of their community, and to maintain their friendships and connections as much as they want good medical care. They want to stay people, not become patients. And we should listen more to what they said. I think the slide that Eve offered at the beginning, the red one, which I'm not going to be able to describe again, was a really good example of maybe how we need to begin to recalibrate our thinking, to re-embrace the humanity of people, and understand that one of our big objectives is to focus on this. One component of the way in which we've taken this forward in Scotland is through the work that we've taken forward on post-diagnostic support. And we now have a commitment that everybody following diagnosis will get 1 year of quality, person-centred post-diagnostic support from a named support worker. And we're in the process of implementing that. And that's taking significant change right across our system. By the time we get to 2016, that will be normal business. That will be a routine component of what we do. The second principle that I'm going to offer is the idea of a quality principle. The idea that care and support must be truly person-centred and should understand care and support from the perspective of people living with dementia, not the perspective of service managers or clinicians. All of our work in Scotland begins from the perspective of people living with dementia and the people who care for them. They keep us honest about the success and challenge us when we need to improve. They tell us how it really is for their day-to-day experience. We, in Scotland, fully endorse the principle of nothing about us without us. And that's where quite often we find that the best ideas come from and the best innovation. And I feel very privileged to speak on the same day here today as Kazuko Fujita, the co-chair of the Japanese Dementia Working Group, and hope that her working group will also work with the Scottish Dementia Working Group, with which I know that they've had contact. Groups like this hold us to our commitments on compassion, dignity, understanding the person, supporting capability, self-direction, engaging and valuing. And every country should have a dementia working group like them. The third and final principle is an effectiveness principle. And a lot of the discussion we had yesterday was around challenges to do with integration, a move from health services to health and social care services, reflecting chronicity and complexity. And this is the point at which our specialist work on dementia crosses over with wider policy on health reform, like in the Netherlands. In Scotland, we're currently going through the largest reform of healthcare since 1948, when we introduced the National Health Service. Improving dementia care is at the heart of that reform process. And I'm going to show a short film to show how services are already being redesigned using that process. The film focuses on Mr. Muircroft, and Mr. Muircroft is the chap in the centre. He's the carer for his wife. At no point in this film will you see the person with dementia. They're from Motherwell. They'd moved to England in the 1980s for Mr. Muircroft's job, but they returned after her diagnosis, mainly to get support from family and friends as they coped and worked with the illness.
Julie was diagnosed in 2009, but she had this illness for 2 years beforehand, I think, and I ignored it because I was just stupid. But she got diagnosed in 2009, and I just thought the world was falling apart, and I had nobody round about me. So that's why I moved up to Scotland here in Motherwell, to be close to family and friends for more help.
My role as a social worker, stroke care manager, is to ensure that there's good partnership working. Without that, we won't meet desired outcomes for individuals and families. Establishing good human relations is extremely important. You can't judge someone's reaction on a phone, you can only hear a voice, for instance. So it's very, very important that we sit around a table sometimes and discuss that, but it's also equally as important as to sit down with an individual, with a service user there that can express his or her wishes in a very open manner.
We get referrals for people over 65 for both functional and organic illnesses. We go out and do our own assessments within their own home. That may involve, like a referral to social work for a further community care assessment. It would maybe a referral to Alzheimer's Scotland if they require Alzheimer's Scotland support in ours. It could be a referral to advocacy.
It's about the person, so it's not about working in silo, it's about working together to achieve the best possible outcomes for the person. So that's involving other agencies, that's involving district nurses, home support, whatever is needed for that person to remain at home and to have the best quality of life.
Liz Aarons is a psychiatric nurse for us, and she comes in here and she'll sit and she'll say, have you got any problems? And if I do have a problem, she'll write it down and she'll phone while she's sitting there. The first one we were put in touch with was Care Watch to come in and shower Julie and dress Julie every morning. And then it was the Alzheimer's lady. She comes in twice a week for 3 hours to give me some time to myself.
Matt, if he's troubled, he'll ask me questions that he might not feel comfortable asking family members. So it's good to have an outsider to have a chat, reassure him, and letting him know that he's important just as much as Julie is, and to reassure him that everything's working well.
And then we were put in touch with cafes that Julie goes to. It's Super Park Dementia Cafe. You go in there and you can speak to a lawyer, a doctor, a benefits maximiser, if you need any information at all.
We recognise the work of the unpaid carer and how difficult that is for them. So part of my role would be to see if there's any supports we can then provide for the carer, if it's linking them into the Princess Royal Trust. Carers Together, we do that. We look at the carer's journey as well. And it's essential that we do that from the point we start working with the person. The care is just as crucial to the overall support as the person.
Partnership works well within my job as a carer, as we can speak to expert sources such as the dental nurse. She can tell us the correct way in order to look after service users' teeth, and as a carer we can bring it back into doing personal care, so as we know we're giving the service user the correct care and attention that they deserve.
I think as a social worker, to know that you're not out there on your own, to feel supported by other services, other agencies, to make sure that your decisions are the correct decisions in meeting those outcomes for families is probably the most important part of my role as care manager.
I think it's a great team to be involved in because we're working together, although we work for different services, but the main aim is to work together to provide a whole service for that person.
Sometimes it is the simple things. It's maintaining a relationship, seeing two people who love each other, stay in their own home with support. It's the little things, you know, and it's a smile. It's a touch of the hand, knowing that someone's been supported and you're part of that. You know, you might be just a small part or a large part, but you're still part of that. And the outcomes, there might be a process to get the outcome, but the outcome is that person being supported and actually being happy in their life, in the community and at home.
Since we came here and got settled in with all these services, life for me and Julie is settled down. And at this moment in time, we couldn't be any better under the circumstances with Julie's illness. We couldn't be any better looked after. It's incredible what's happened in Julie and I's life. Because these services are just, they're brilliant actually, you know.
When we met the Muircrofts, I was really quite surprised that Julie Muircroft wasn't actually in a residential setting. But the team that have been built around Mr. Muircroft to enable him to care for his wife have enabled them to stay in their own home and to live lives as part of the community, which was his objective. We need to, I think, recognise this more in how we think about care for dementia. There is an equal need to support people caring for people with dementia as there is in supporting people living with dementia. Indeed, that could be a fourth design principle. But just as importantly, the film shows that dementia is not about numbers or costs or projections into the future. It's probably not even about strategies or policies or programs. It's about person-to-person care. Ultimately, the work that we do in dementia comes down to personal relationships, and anything that we do needs to be tested against our ability to maintain those. So, what do you think? What should the principles for care be? How might we develop a process collaboratively to develop consensus on what really matters? How can we make things happen faster to deliver the improvements in quality care that we're all ambitious to deliver? These were the three principles which I offered. I'm really just trying to get the conversation started here, but to truly try and boil it down to the things that we have to do really well, and if we have to share knowledge on and work together on. Tell me what you think, but also tell the WHO, OECD, EU, tell your friends, have discussions, argue about it, fall out, but let's reach consensus and let's take this forward. Thank you.
Thank you, Jeff, for this sharing these principles and the real-life example, and we'll feed that into the discussion here and after during the lunch and the pauses as well. Now, I would like to move to another country, France, and I will ask Étienne Hirsch from the French Institute of Neurosciences, Cognitive Sciences and Neurology and Psychiatry in France to share with us some of the elements of the French experience relative to timely and appropriate prevention and care.
Thank you, Yves. It's a great honor for me to share with you the French experience on the timely and appropriate prevention and care. As in many other countries, today in France, older subjects are anxious about their memory. This is the consequence about awareness on dementia and Alzheimer's disease. Memory complaint is now almost the rule. Complaint, however, is not correlated with objective memory performances, and we have to provide to those people a correct and accurate diagnosis. In most of the cases, complaints are related to attention disorders, depressive mood, anxiety and professional stress for those who are still active, drugs, sleep disorders, sleep apnea, normal aging. So this first analysis is done generally in our country by the general practitioner who can provide an answer to the patients. However, for more complex cases, one has to go, in fact, to more sophisticated analysis, and they are referred to neurologists, geriatricians, or psychiatrists. but often the family and the people who are taking care of the patients are refusing to obtain a diagnosis. And there are 4 arguments put forward against an early diagnosis for Alzheimer's disease and dementia. First, they are saying there is no desire to know. The patient doesn't want to know that he is affected by a disease that cannot be treated. 2, there is no certainty about the diagnosis. We are still lacking good tools to provide a definite diagnosis. 3, nothing can be done for the patients. And 4, there is a risk of catastrophic reactions. So what I would like to do now is to show you that in fact this is absolutely not true and that adapted care can be provided to the patients. There is no desire to know. In fact, a survey shows that in France, as in other countries, 97% of the people want to know themselves if they are suffering from dementia. So this is not true. The people really want to know if they are affected. Of course, there are 3% of the people who don't want to know, and you don't have to give the diagnosis to those people. 2, there is no certainty of the diagnosis. An early diagnosis is very difficult. Again, we have now better tools. Of course, Alzheimer's disease is a memory disorder, but we have memory disorders which are due to other causes: vascular lesion, frontotemporal dementia, confusion, MCI, subcortical dementia, drugs, depression, sleep disorders, normal aging. All this can be, or at least Alzheimer's disease, can be discriminated from the other form of dementia by specific memory tests. And for instance, Bruno Dubois, who helped me in preparing this presentation, developed an algorithm to identify Alzheimer's disease, which is a storage deficit, whereas other conditions are rather retrieval deficit. And by queuing, in fact, you can discriminate, because in Alzheimer's disease there is no total recall, while in the other forms there is a rather normalized answer. Furthermore, when you combine the specific neuropsychological testing with MRI, you can exclude other causes, vascular tumor, hydrocephalus, etc. And MRI shows a precocious atrophy of the hippocampus. So this needs, in fact, specialized centers, memory centers that we have developed in our country to provide an accurate diagnosis. And the fact that the diagnosis is more difficult at early stages is less true these days. Finally, there is nothing to do. Current available non-pharmacological treatment, in fact, can help the patients. Of course, we have no drug to slow down the pathological process, but we can improve the symptoms. Cognitive stimulation is effective on cognition as a symptomatic drug. Cognitive rehabilitation can help. Behavioral therapy applied by informal carers as co-therapists. Support group for informal carers improves quality of life. Physical activity improves the life of the patient. Multi-component caregiver intervention. And despite we are using art and musical therapy, there is in fact less scientific evidence that it really improves the quality of life of the patients. Finally, the risk of catastrophic reaction. A disclosure of the diagnosis, in fact, enables the patient to make important life decisions, financial and legal plans while still competent. And in our country, we have social workers that allow, in fact, those patients to make the right decision, participate in planning of his and her future, make living arrangement, move closer to children and family, go to elderly homes, and finally benefit of resource of healthcare system, take appropriate step to prevent injury stop driving, stop using weapons, and be involved in treatment decision. So all this is in fact developed in a three-level organization. Level 1 with the GP, I already mentioned that. The level 2 are the memory clinic or the specialist. This allows the patient to stay at home with appropriate care. And finally, level 3 are the regional expert center. These are the highly specialized centers that are involved in clinical research and clinical trials. So thanks to the Alzheimer plan in our country, we have in each region these very specialized centers. We are covering the whole country with specialized neurologists and in fact specialized neurologists for dementia and memory problems, and of course the GPs are covering the whole countries. So in summary, this has been conceptualized through the second Alzheimer plan, 2008-2012, and on October 18, we will launch now the new plan, which will follow the Alzheimer plan, which is a plan on all neurodegenerative disorders. As I mentioned in the differential diagnosis, in fact, dementia is not a single entity. There are many commonalities with other neurodegenerative disorders, and we believe that we will learn for dementia from the other neurodegenerative disorders as the other neurodegenerative disorders will learn from dementia. However, we have to preserve the specific care for patients with dementia, for patients with Parkinson's disease, for instance, in another organization, and so on. Thank you very much for your attention.
Thank you, Etienne, for sharing this France experience. And before engaging into some time for discussion, I would like to invite now Jeff Huber, who will provide the perspective of a US-based international service provider, Home Instead. So, Jeff?
Thank you. Ladies and gentlemen, in a few short years, there will be 1 billion people over the age of 60 worldwide. The age pyramid, where the oldest population is the smallest at the top of the pyramid and the youngest at the base, will literally become inverted. This has never happened in the history of the planet. This historic and unprecedented demographic shift, combined with a surge of Alzheimer's disease and other dementias, combined with a surge in chronic conditions, combined with a diminishing supply of healthcare workers, combined with the shrinking financial resources and increased demands, presents what I argue is the greatest social challenge in the history of the planet, and certainly the greatest in our lifetime. Healthcare systems, governments, society itself is completely unprepared for this phenomenon, a shift that is transforming markets, workplaces, and communities. Traditional models of caring for our aging loved ones are simply unsustainable. That's why the theme of this summit, New Care and Dementia Models, is exactly the right focus. Because in the face of this historic challenge, it will take new and innovative care models. It will take political will for major structural reforms. It will take increased collaboration between governments, NGOs, and the private sector. And it will take new and innovative business models to play an important role in how we age differently and better, and therefore create new opportunities for economic growth. I'm pleased to be here as a member of the Global Coalition on Aging, which is the global business voice on aging, policy, and strategy, and I'm also pleased to be here as the president of Home Instead Senior Care. Home Instead Senior Care fills a critical need with an innovative and effective new care model, which is both scalable and sustainable. Working with the Global Coalition and our other corporate members from across the globe, Home Instead is expanding the world's capacity to care, and we are striving to change the face of aging. Home Instead was founded in 1994 by Lori and Paul Hogan and inspired by their own personal caregiving experience with Paul's grandmother, Eleanor Manhart. At age 88, doctors gave Grandma Manhart only months to live. But the family's commitment to keep her at home restored her will to live, And in fact, she lived comfortably in her own home for an additional 11 years. Today, we have franchise operations in 17 countries and have grown to 640 franchises in the United States and Canada, and nearly 400 outside of North America, totaling more than 1,020 franchises worldwide. Today, this very day, more than 65,000 highly skilled, professionally trained home instead caregivers will provide excellent quality of care to 65,000 clients in their own homes on 4 continents. Last year alone, we provided more than 50 million hours of care to our clients, and approximately 60% of our clients have Alzheimer's or some other form of dementia. I'm also proud to note that the Duskin Companies, who is represented here at the Legacy event, was our first franchise partner outside of the United States. They opened their first office in Osaka in 2000, and today they have more than 100 offices throughout Japan. At the center of what we do, we promote active and healthy living, and we aim to extend life with highest quality. These are our care objectives, which we achieve in 3 main ways. First, through person-centered and relationship-based care. Home is more than a place. It is someone's identity. That's why 90% of seniors want to live in their home as they age. We help them to achieve this intense desire to age in the comfort and security of their home by focusing on relationships, not tasks. We focus on who our clients are as unique and special individuals. We honor their humanity and who they are as people, which allows us to create personalized and individualized care solutions. By focusing on the person and creating a relationship with that person, allows us to care for them much more effectively. This relationship-first approach makes performing tasks, often sometimes very intimate and personal tasks, such as giving a person a bath, much easier and more effective. Second, we have a specific emphasis on Alzheimer's and other dementias. We created a cutting-edge, research-based Alzheimer's training program for our professional caregivers. We have a dedicated website, helpforalzheimersfamilies.com, which has helped more than 1 million visitors since we launched it in September of 2012. We published a book, Confidence to Care, which helps family caregivers dealing with the challenges of Alzheimer's disease. In less than a year since its publication, we have sold more than 20,000 copies and it's been published in 5 languages. We have an app, the Alzheimer's and Other Dementia Daily Companion, which helps caregivers in the heat of the moment on how to care for their loved one. Third, we provide free resources to the family caregiver. As you well know, Alzheimer's disease does not just affect the person with a diagnosis. Instead, it affects the entire family and can be all-consuming and devastating on the family caregiver's health, job, and personal life. Whether someone uses our services or not, we feel an obligation, a responsibility to help them care for their loved ones and to take care of themselves. For example, we offer the same training that we offer to our professional caregivers to families free of charge. Since September 2012, we have trained tens of thousands of family members in more than 5,000 in-person training workshops, and we have trained an additional 30,000 individuals online by way of a free online e-course. We have a free resource site, caregiverstress.com, which offers additional resources to families, helping them with having difficult conversations, managing the stress of caregiving, and protecting seniors from fraud. We are the exclusive partner for Seth Rogen's nonprofit organization, Hilarity for Charity, and our franchise owners have donated more than $1 million in free care grants to families coping with emotional burdens. All of this helps to alleviate the physical and emotional stress that family caregivers feel and replace it with peace of mind and time to focus on their work, personal health, and other family obligations. Here's a list of services that Home Instead provides. I want to focus on the Alzheimer's services. Particularly, I'd like to focus on managing difficult or challenging behaviors. This is where our person-centered, relationship-based approach is particularly effective. By understanding the individuality of the client and the history of that person at a very deep level, we're able to redirect and manage difficult behaviors much more effectively. The Home Instead Network is committed to advancing quality care and the highest level of customer service. Our professional caregivers receive ongoing training to ensure that they have the most up-to-date techniques, which ensures quality. We assist with healthy behaviors that lead to active aging, and of course, staying physically active, eating well, practicing good wellness habits. We ensure that our clients are engaged and supported, while remaining safe in their home. We can help at any point along the senior care continuum and enhance outcomes at each stage. We can help when seniors are fully active and independent by way of companionship and social interaction. We can help when primary caregivers are family members and need support to balance their lives. We can help with hospital stays and all points along the care continuum process. And we can offer support to seniors when they are in a care facility and in the final days with hospice support care. Our type of care is tailored to meet the needs across all stages, has incredible value, and leads to great outcomes. What we've learned through our vast experience and our research, whether in the United States or Australia, Ireland or China, the Netherlands or Japan, is that personalized care produces positive outcomes. Here are some of the positive outcomes that we have measured. In recent research, which we conducted in the United States, which is our largest market, which included those who have received professional non-medical care and those who have not, we found significant improvements for seniors and their families who had professional care, particularly those with Alzheimer's and other dementias. For example, for those with professional care, the amount of time that they had in care doubled. We did not replace the care that families provided, we supplemented it. Those who had professional care had 50% fewer doctor's visits. Those with professional care had fewer hospital admissions. And the quality of care was rated as good, if not better, than that provided by family members. The simple bottom line is this: people who receive professional in-home care receive more care, better quality care, with better outcomes. They utilize the healthcare system far less, creating huge savings, and they get to age exactly where they want to be, in the comfort, safety, and security of their own homes. Thank you for allowing me to share with you our unique home care model. I look forward to learning more from each of you and building new partnerships in Japan and globally to help care for as many seniors, particularly those with Alzheimer's disease. Thank you.
Thank you, Jeff, for providing the point of view of business to the care challenge. So we heard the speakers, we heard yesterday. The session started a little bit late, so I will use some of the minutes in order to allow for some questions or comments from the audience. Please feel free to ask or comment in English or Japanese, because we do have the means to listen to your comments. So raise your hand if you want to ask a question at this point or make a comment. Dr. Hashinsky.
Yves, in one of your slides you had costs. Could you kindly comment on that?
Well, it costs a lot to comment, but I was simply reflecting yesterday the importance of the cost issue and the importance that was raised in the session yesterday of the health economics dimension of this. And this was a recurrent topic. Maybe some of our speakers want to comment on this. Jeremy.
Can I just emphasize one aspect of cost which is important? So we know there is cost, and probably unsustainable cost, to national governments if we don't change the way we support people, but it's also the cost to the family. And we did some research in the UK earlier this year. We published some research that was done by the London School of Economics, and this showed that to the family in the UK, the average cost, because this is not paid for by the National Health Service, it's cost to themselves for social care, the cost is £20,000 per year for a family with someone with Alzheimer's. So there's both the cost to the national economy, the cost to the state, and the cost to the individual family.
Thank you.
While you are thinking about any other comments, I would like to ask to some of our speakers, for instance, Jacqueline, how do you plan to evaluate? Because there's a lot of very important ideas and new ways and innovative ways, for instance, this long-term care. So how will you make sure that you have a valid evaluation of the impact of the program in the sense that you want it to be?
Yeah, thank you, Yves. I can say we're planning to have a constant monitoring of all effects of the long-term reform, and this will be a constant measurement on monitoring, and annually we'll have evaluation of the effects.
Any other speaker wants to comment on the importance of evaluating their program as they are either deployed or have been deployed? France, who has deployed for a number of years now.
Yes, I think, Yves, you are raising a very, very important issue. When we are discussing pharmacological treatment, we have always the placebo arm, and it is very important for the non-pharmacological treatment to have a really scientific way of evaluating. And this is, for instance, one of the measures we want to implant in the new plan on neurodegenerative disorders in France. Interestingly enough, there was at the beginning of this year a study which was published in the Lancet Neurology for Parkinson's disease, evaluating in fact the care system as compared to the specific care system as compared to the normal care system, and unfortunately with very valid methodology, there was little improvement with the specialized care system. So we have to be extremely careful.
Jeff, you want to comment?
I think it's really difficult to evaluate. If I was looking at a part of Scotland where we might be doing a particular group of interventions, the likelihood is there that we're going to be doing something like dementia cafes. We might be doing something on post-diagnostic support. We might also be doing something on care coordination. There'll be material which is coming in terms of work that we're doing around housing. And so it's very difficult to actually attribute the benefits to any particular intervention in that space. I think what's very important, though, through the process is that all the work that we do is done in the context of generating information about what outcomes we're achieving. And at the moment, we're still developing systems, I think, across most countries, which enable us to track change over time in terms of people's experience in living with dementia. So we might be looking at things like longitudinal studies, which can actually understand how things change as policy and interventions change. I think the other challenge that we also face is very few people with dementia only have dementia. The real wake-up call for us around integration of health and social care was, in Scotland we now have more people under 65 living with multiple chronic conditions than over 65. And so the discussion that we took into integration, which was resolving issues to do with old age care, is really a set of challenges which are for people from 40 upwards and needing to understand that, and that just makes any evaluation very difficult.
And I'm sure you would agree that all of you, that the qualitative evaluation and the narrative will be important and not only the objective ones. Jeremy.
Exactly, Yves. I think that's absolutely right. And the program we have that Alzheimer's Society runs is that every single one of our 3,000 services over time is evaluated. And the starting point of that evaluation is what we call the Service User Review Panel, where we actually involve the people using the service to get their expression of what has changed in their quality of life and actually put some measurement on that. And the important thing is to recognize that we need to listen to the voices of all people with dementia and their family caregivers. It's easy to fall into the trap of only listening to the people with early stage dementia because it's easy for them to contribute at conferences, to speak out, but we have developed methodologies that allow us to actually listen to the voices of people at more advanced stages of Alzheimer's and dementia as well.
Dr. Hasegawa?
Would you like to say just a few words That's the evaluation of the system, or なんて言いますか?
So how shall I say, planning? It's very important to evaluate any program and planning, but eventually, ultimately, what's important is for us not to forget that people supporting people, that element. We are working on community building. And, you see the bracelet that I'm wearing right now. The supporters for those communities, once they go through some training and lectures, learning basic things, and they become full-fledged supporters, they can be granted with this bracelet. And then there are 5 million such supporters who are out there right now. And following this movement since last year, we have a so-called Orange Plan by the government started off. And this is to provide home care and professional care, professional experts visiting people living with dementia at their homes, which is excellent. But one consideration we need to take is that we are really super aging society, and we are number one in the way of the number of people living with dementia in this country. And given that, what shall I say? Well, people supporting people. People need to be aware of the importance of people supporting people, and that awareness needs to be there among the general public. So the power of neighborhood, something I would like to claim. In a community, ordinary citizens supporting other ordinary citizens, that is very important. And unless that is achieved, the Orange Plan will be just another ideal and not the reality. So that's why awareness raising is very important. And this bracelet, Orange Ring and Orange Plan, this is the history of this plan. And another thing is in the countries in Southeast Asia, I think over there in those countries, the speed of aging is actually faster than that of here in Japan, meaning that they will see a lot more people living with dementia in the future. And I think these countries are looking into Japan because we are the top runner, and they are paying a lot of attention to our initiatives. And also TV reporters come from those countries to Japan to learn from us. So they are looking at us. And in this context, what is most important is that, of course, each country is different, but Japan needs to communicate appropriate information to those other countries. And in this, what's most important is peace. Peace needs to be there for communication. That's all. Thank you very much.
We're running a little bit late, and I'll have just the last comment from the floor, and I see George Radenberg here with a comment. And maybe with the microphone.
I was intrigued by the comment of Mr. Huber that in fact deeper, more personal and very effective professional care reduces use of the medical system, which implies that deep improvements in the quality of care can reduce the cost of the healthcare system overall. So I'd be curious as to whether or not there is available any suggestion at the national level, perhaps Jeff Huggins, whether or not the improvement in the quality of care that you're introducing into Scotland has demonstrated any reduction in the utilization of the healthcare system and the medical system, and thus the potential offset of the increased cost of providing quality care with reductions in the utilization of the healthcare system.
A brief comment?
I'll try and be quite brief. Probably two points to make. The first is our assessment is that unless we improve social care significantly, we will not be able to build hospitals fast enough to actually deal with the future care needs. So if our model is biased towards hospitals, we cannot sustain that over time. So better social care probably enables us to stand still in terms of the costs of medical care. The second comment is we're beginning to see the challenges of poor quality, slow development of social care. Across the UK, I think it's fair to say, it has not kept up with the growing demographic demand, and the consequence of that is now beginning to be felt really acutely in our hospitals. So it's now being presented across my jurisdiction, across the UK, as a problem in hospitals. But the main problem that we have at the moment is around the availability and the quality of social care.
Thank you. At this point, I will have to bring this session to an end. I think it was a very, very fruitful session. I think that the discussions that should evolve towards not only evaluating and learning, but also sharing and probably evaluating across nations and jurisdictions. I think this is very important. So on behalf of all the speakers and all of you, I would like to thank everyone. Thank you for being here, and thanks for the organizers for having allowed me to chair this session. Thank you so much.
Thank you. Now we'd like to break until 11:45 for coffee break. Until 11:45 we would like to have the coffee break. And the topic to the speakers and the chairpersons. By 11:45 please be gathered at the waiting room number 2. And in front of the screen, Kunimiro Yasuhiro-san, the photographer, is taking the photos about the faces and the livelihood of the people living with dementia.